Welcome to This Explainer. We're diving straight into a highly clinical, genuinely life-saving medical tool, the Partograph. It might actually surprise you to learn that this simple piece of paper was championed back in the 1970s, yet it's still the absolute gold standard in modern obstetrics today. If you've ever wondered how medical professionals take the sheer, overwhelming complexity of childbirth and turn it into something trackable, actionable, and safe, well, you're in the right place. We're going to break down exactly how this ingenious graph operates as a critical safeguard in delivery rooms worldwide. So let's kick things off with a pretty high-stakes question. How do doctors safely monitor the inherent unpredictability of childbirth? Labor is, by definition, an incredibly dynamic, constantly shifting process involving two patients at the exact same time, the mother and the baby. Trying to keep track of all those changing variables just in your head? Yeah, that's a recipe for disaster. And that is exactly why the medical world relies on what is essentially the ultimate visual dashboard for labor. It takes all that chaos and distills it into a single, standardized visual narrative. And that dashboard is the Partograph, or as it's sometimes called, the Partogram. It's a graphical tool heavily recommended by the World Health Organization to monitor active labor. But it's not just about charting numbers for the sake of it, right? This single document answers four vital, highly time-sensitive questions. Is labor progressing normally? Is the baby tolerating labor well? Is the mother stable? And absolutely most importantly, is intervention needed right now? By answering these questions in real time, healthcare providers can spot abnormal labor early, stepping in way before complications become severe. So here's our roadmap for this explainer. We're looking at 1, the passenger, which is the fetal condition. 2, progress, tracking the labor itself. 3, the patient, meaning the maternal condition. And 4, the alert and action lines. All right, let's jump right into section 1, the passenger, focusing on the fetal condition. Now, a normal fetal heart rate sits right between 110 and 160 beats per minute. On the Partograph, this gets recorded every 30 minutes. If that heart rate spikes above 160, which we call tachycardia, or drops below 110, bradycardia, those are immediate red flags. Anything outside this normal range could mean the baby is in distress. This could be due to cord compression, maternal fever, maybe placental insufficiency. Basically, it's a vital, ongoing pulse check to make sure our passenger is doing okay. Next up, amniotic fluid. Medically, this is referred to as liquor, and it's carefully tracked using a set of specific letter codes. I simply means the membranes are still intact, but if they've ruptured, providers have to look closely at the fluid itself. C stands for clear, and that's exactly what you want to see. Completely normal. But if they log an M, meaning the fluid is meconium stained, well, that's a serious warning sign for fetal distress. And a B for blood-stained fluid? That could point to something as critical as a placental abruption. It's crazy to think that just one single letter on this graph speaks volumes about the safety of the environment inside the womb. Also within this passenger section, doctors track something called molding. Now, molding is the physiological overlapping of the fetal skull bones as the baby navigates the birth canal. A grade of 0 means the bones are separated, which is totally fine. But if you see providers logging 3+ signs indicating severe, fixed overlapping of those skull bones, the dashboard is basically screaming that there's a major problem. It strongly suggests obstructed labor or cephalopelvic disproportion. In plain terms, it means the baby's head is just too large to pass through the mother's pelvis safely. Moving right along to section 2, progress, where we actually track the labor. Now, it's really important to note that providers don't just whip out the Partograph the second a pregnant woman walks into the hospital. They wait for a very specific trigger, and that's active labor. Modern WHO recommendations define this as the presence of regular, painful contractions coupled with a cervical dilatation of roughly 5 centimeters or more. Older guidelines actually used to start at 4 centimeters, but modern standards wait for that 5-centimeter mark of progressive cervical change to really begin plotting the data. So the actual dilatation journey goes from a normal cervix at 0 centimeters, hitting active labor at 5, and working all the way up to fully dilated at 10 centimeters. On the paper graph, this progress is plotted using X marks. The medical team literally connects these X's over time to visualize the speed of labor. They're generally expecting it to progress at a rate of approximately 1 centimeter per hour, though, as we all know, labor patterns definitely vary from person to person. Right alongside that cervical dilatation, the doctor or midwife is also tracking the physical descent of the baby's head down the birth canal. But instead of X's, this gets plotted with O marks. They measure this by abdominal palpation, grading it from -5 to +5, or by noting the fifth palpable above the pelvic brim. In a normal labor, you want to see that head gradually moving down. A failure to descend, that's a massive clue. It warns the team of a possible malposition of the baby or an outright obstruction. The final piece of this progress puzzle is uterine contractions, and these are documented every 30 minutes. The Partograph uses this really clever visual shading technique to capture three things at once. First, frequency, so the number of contractions in a 10-minute window. Second, duration, categorizing them as lasting under 20 seconds, 20 to 40 seconds, or over 40 seconds. And third, strength, which is done visually. You use light shading for weak, half-shaded boxes for moderate, and fully solid dark boxes for strong contractions. It gives anyone just glancing at the chart an absolute instant read on the engine driving the labor. All right, let's shift gears to section 3, the patient, focusing entirely on the maternal condition. Here, the Partograph acts as an incredible early warning system for maternal red flags. Her pulse is checked every 30 minutes, and we're looking for a normal 60 to 100 beats per minute. Blood pressure and temperature are logged every 4 hours. Why? Well, a sudden spike in blood pressure could mean preeclampsia or eclampsia, while a fever points to a possible infection like chorioamnionitis. Even her urine is checked. Finding ketones might suggest maternal dehydration or starvation, protein might again point back to preeclampsia, and sugar suggests possible diabetes. All of this monitoring ensures the mother has the physical reserves to actually continue the labor safely. Finally, we arrive at section 4, the alert and action lines, which act as the built-in tension mechanism for the whole dashboard. Understanding the difference between these two diagonal lines printed right on the graph is absolutely crucial. The alert line begins exactly when active labor starts, moving diagonally up at a rate of 1 centimeter per hour. If your plotted X marks stay to the left of this line, you're golden. Labor is normal. But if the plot crosses the alert line to the right, it simply means watch closely. Now the action line, that's drawn exactly 4 hours to the right of the alert line. Reaching or crossing that action line, that is the Partograph sounding the alarm. It means assess immediately, intervention is likely required. Let's look at how this plays out in a normal, healthy scenario. Say a woman is admitted at 5 centimeters dilation. 1 hour later, she's at 6. 2 hours later, she hits 7. Fetal heart rate is a steady 140, contractions are getting stronger, the head is descending perfectly. Because she's dilating at least a centimeter an hour, her graphed line of X's safely stays to the left of the alert line. Any medical professional can look at that paper and know, instantly, that everything is progressing exactly as it should be. Conversely, imagine a situation where dilation just stalls. The cervix hits 6 centimeters, but then it just stays there, hour after hour. First, the plotted line will drift and cross the alert line, so the team ramps up their observation. But if more hours pass and that plotted line drifts all the way over to cross the action line, the medical team has to step in immediately. They need to figure out why labor has stopped. Is the baby in the wrong position? Are contractions just inadequate? This is the exact moment where critical decisions about augmenting labor with medication or moving to an emergency operative delivery are made. So to lock all this incredibly vital information in, whether you're a medical student studying for exams or just someone fascinated by medical science, remember the 3 P's trick. Passenger is the baby's condition. Progress is the mechanics of the labor itself, the dilation, the descent, contractions, and those critical alert and action lines. And patient is the mother's systemic condition. Honestly, it is the ultimate mental framework for mastering this medical dashboard. And that brings us to the end of our explainer. You know, in an age of incredibly complex digital technology, it's just amazing that a simple, cost-effective, standardized paper graph is often what stands between a safe delivery and severe complications. By forcing observation and standardizing the timeline of labor, the Partograph actively prevents postpartum hemorrhage, fetal distress, birth asphyxia, and maternal exhaustion in delivery rooms across the entire globe. It is, quite literally, a lifesaver on a single sheet of paper. But as hospitals rush to digitize every single aspect of healthcare, we have to ask, will a digital screen ever truly replicate the immediate, undeniable urgency of ink crossing the action line? Think about that for a second. Thanks for joining us, and we'll touch you next time.